I'm going to ask everybody to take a seat. That's great. Sure.
Say something.
Hello. Hi.
Good.
I want to welcome everybody to this evening's presentation on the Affordable Care Act. My name is Joan Farrow, and I'm going to be your moderator tonight. And I'm very excited about this presentation. We have some fabulous speakers on very, very timely topics, and I personally have been looking forward to hearing what they have to say for several months, so I hope you'll enjoy the presentations as much as I know I will. Before we get started, I want to just mention a couple of housekeeping issues. If you have a BlackBerry, would you please shut it off? It turns out BlackBerries are uniquely able to interfere with AV equipment, and if you get one of those text messages or an email message, it makes a buzzing in the AV equipment. We are recording this and videotaping this presentation for future publication on our website, so we are interested in having the best quality recording we can get. I also, just in case you do want to get onto the web, the site is Wolfie.net Guest, and that is open, and it has no password connected with it if you need to get out there and see what's going on in the world. But if it's in a BlackBerry, don't do it. Ladies and men's rooms is in the hallway behind me. You can exit over by the place where you entered and just walk around and you'll find them. We're going to try to hold the questions until the end. We're at the end of everybody's presentation. There will be an opportunity. We're going to have a panel, and you'll have an opportunity to ask questions. And finally, if you're interested in either CME or CNE credits, please be sure to fill out the appropriate paperwork at the desk when you exit. So, having said all of that, I'm going to show you a picture. Oops, no, I guess I'm not. Wait a minute. There we go. This is President Obama signing into law the Affordable Care Act on March 23rd, 2010. Also known at that time as the PPACA, or the Patient Protection and Affordable Care Act. And did a little research on this because I remember when it was issued, the sort of flurry to try to understand what it all said, and it was published in 906 pages, so I don't know if anybody actually read it. We all waited for our local people and national people to boil it down into some bullet points that we can understand, but it still has lots of ramifications that are coming out. I think that there are many phases to this act and how it gets phased in, and it will continue to be phased in until 2010 and beyond, I believe. But you're going to hear more about the details of that from some of our speakers. I want to take this opportunity to introduce Dr. Pamela Nowak. Dr. Nowak has an illustriously long history in sorry, not long, but an illustrious history. Sorry. Well, it's a lot shorter than mine, so. In hospital administration and both in operations, finance, and strategic planning. And right now, she is an assistant professor in the Department of Healthcare and Policy Management at Stony Brook. And teaches quite a bit on the various strategies and financial aspects of healthcare administration. Her primary research interests are healthcare delivery and comparative outcomes assessment, and the title of her presentation is a brief overview of the ACA. She's going to take us through titles 1 through 10 in a matter of minutes. So welcome to Dr. Nowak.
Thank you. You have to give me instructions on how to use this.
Oh,
The right arrow, the
arrows?
right arrow will advance one at a time.
that's not that.
A brief overview. You may see it. So I come at this as an economist, and speaking as an economist, this healthcare reform is about unequal knowledge, because unequal knowledge in our healthcare system causes market failure. Market failure over time has created a situation where people have poor access. Some people have poor access, and the costs continually go up. So as that happens, and then we hit a downward cycle, a recession, we have real tough pressure on access and very tough pressure on costs. As the costs rise, the businesses get upset. As people can't get access to healthcare, they get upset. And we have a different situation than we have during a positive cycle. So the healthcare reform is presented to the public as looking at ways of solving access, very important, and also trying to take care of some of the problems that businesses have with costs, also very important. We have 10 titles. The first one is really about insurance, and the insurance title is really here to address the access issue. So we have no individual rated health insurance policy starting in 2014. So if I'm high risk, I can't get a higher rating than you, and I can't be forced to pay thousands and thousands of dollars for my insurance. Most Americans need to obtain insurance by law, or they pay a penalty. Financial subsidies are going to make it possible for everybody to have insurance. State and federal healthcare exchanges are right now being set up, and I think many of them will be state-run, but many of them will be federal-run, and a few of them will be shared. No lifetime annual benefits for limits. So if I'm chronically ill, I don't run out of my benefits after 20 years. If I get really bad cancer and I'm treated 3 times, I don't run out of my benefits. And children age 20 up to 26 can be on their parent policies. And this started in 2010. So this is to alleviate some of our immediate access problems. Title II looks at the public programs and also really looking at access. It's improving its intent was to improve the Medicaid benefits and standardize them for Medicaid beneficiaries. However, the Supreme Court did strike down the ruling that all the states had to improve their benefits packages for their poor to raise their ceilings, and it also does require mandatory quality improvement. So it's, again, expanding financial access. That was the intent. Title III looks at improving quality and efficiency, and if you look at the goals, effectiveness, efficiency, and patient-centered care, you really have the triple aim. And added into that triple aim, you have a little bit of focus on getting the patient engaged. That third one, patient-centered care, talks about maximizing population health and getting the patient to be the agent of change. So it's the triple aim, but let's look at the patient and get the patient engaged. And some of the things that the title talks about are increasing preventive benefits and then going out and trying to get the patients to use it by not making them pay, reducing the donut hole. That's the Medicare drug thing where after you hit a ceiling, you don't get any drug benefits for a while. And what that does is it helps get access to vulnerable populations. And for the cost, we reduce Medicare spending by $450 billion over 10 years. This Title IV, I think, is a continuation of this triple aim kind of thing. It's really aimed at chronic disease and public health. There's a national workforce, did that wrong. There's a National Prevention and Health Promotion and Public Health Council that will be established, and it's been funded with $13 billion trust fund. Insurers are required to provide evidence-based preventive services, but we don't really know very much about what those are going to be yet. and restaurants are required to post calories on their food. So here again, we're looking at, well, there's a lot of information inefficiency, and these are our ways of addressing information inefficiency, and also dealing with provider moral hazard that I treat when it's acute, but I don't treat when I can prevent it. There's a workforce bill, Title V. We want to establish a national workforce commission so that we can analyze what our new health force will need, because we don't know what it needs, and we probably don't have the right types of employees in the labor force right now. Particularly, we want healthcare to be community-centered, so we want community health center funding, and we want different types of labor that can function in the community. So in addition to primary care, we are looking at training community service workers who might be going and making home visits to communicate with patients somewhere in the continuity of care. We need care coordination. We don't have a lot of care coordination, so that would be training new nursing people to do care coordination. And also, we're really looking at changing the role of nurse practitioners and physician assistants in delivery of care and allowing them to do much more primary care services. In terms of transparency in the program, again, transparency is about information. So if we have a good program and it's financially transparent, then we reduce fraud and abuse. We require public reporting of gifts to suppliers and from suppliers so that pharmaceuticals can't send all the doctors to Tahiti and give them a really good time and then they buy their drugs. That would never happen, right? Establish a patient-centered outcomes institute as a public-private entity to support clinical outcome research. So here we're talking about being able to see what interventions, what treatment interventions actually work and documenting that, and then turning to those as the correct care for patients who need them. And there's a long way to go on this, but there is this institution out there and it is active now. Nursing home transparency regulations and Elder Justice Act, particularly to fill knowledge gaps again, and knowledge gaps for our most vulnerable population, who are the elderly and the poor. Improving access to medical innovative therapies. The FDA instructed that they wanted a pathway developed to get biopharmaceuticals, a generic-like biopharmaceutical marketed. So more access to medications at lower costs, try to address the anti-competitive efforts to keep generic drugs off the market, and provide discounts to hospitals and communities serving low-income patients for pharmaceuticals. I don't know that it went far enough to solve the market problems that surround the drugs, our pharmaceutical pricing, and I think we just had some recent backlash on that with the sequester and the impact of physicians who were doing chemotherapy in their offices. A lot of them are saying that they can't really afford to do the top end of that because of the cut to their reimbursement. Title VIII was supposed to talk about long-term care insurance, but it's been abandoned, so we don't really have to talk about it. Title IX talks about revenue provisions. So this is kind of a funding bill. There's going to be new Medicare taxes levied on high-income wage earners, new taxes on corporations, and we have a list of them. And again, so this is the idea that those who stand to gain from the bill, if you're in the pharmaceutical industry, if you're a healthcare provider, of course you're going to gain from the bill. So then there are some taxes levied on you, and that's where they're going to come from. And then there are taxes, kind of sin taxes. So for some reason, a 10% tax on indoor tanning salons. That's a sin tax. Unless they had a Title X, quality and affordable health care for all Americans, This was the act that kind of enabled the legislation to exist and tied it all together. It does have some reauthorization of Indian Healthcare Improvement Acts and some other miscellaneous rules, but I think it was more there to enable like a final resolution and reconciliation. And that's my brief summary of the Affordable Health Care Act.
Thank you, Dr. Nowak. So with all of that to get done, no wonder it's going to take us to 2020 to roll it all in. And be interesting 7 years from now whether we'll see it all happen. Kathleen Schur is going to speak to us next. She's currently at the Greater New York Hospital Association. She's a senior vice president, and she's involved in health reform policy matters that involve coverage expansion. She has previously worked at the Department of Health in the Office of Managed Care at North Shore LIJ, in the Management Services Organization, and at HIP as a senior vice president of provider relations and government. Kathy's going to speak to us about healthcare exchanges and how they're going to be implemented. Many people are wondering what they are. They also wonder how they're going to work, and what kind of timeline and what it's going to look like in New York State. And I think Kathy's going to help us understand all of that. Thank you.
Thanks. Hi, everybody. So Pam gave you, a broad overview of everything that was in the Affordable Care Act. Much of that has actually already been implemented or is in the process of being implemented. What I'm going to do is focus on some of the really big changes that are going to kick in 2014, and some of the things that people automatically think about when they think about health reform. Those things are mostly going to happen in January of 2014. Okay, so starting in January, there are 5 major pieces that I want to talk about. So first of all, as all of you know, there's a requirement in the ACA that individuals have health insurance or pay a penalty. That begins in January. There's also a requirement that employers, if you have more than 50 full-time employees, you must offer adequate insurance or be subject to a penalty. Medicaid income eligibility is expanded. Originally it was supposed to be expanded across the country to 138% of the federal poverty level. Now that has become optional for states, but most states, I don't think it's the majority yet, but close to half of the states have already decided that they will implement the Medicaid expansion. And then the things that make all this possible is that there are subsidies that will be available beginning in January for people that earn up to 400% of the poverty level. And we'll talk about what that means later. And there are also tax credits that are available to small businesses, to certain small businesses, that will reduce the cost of coverage to them. And those last 2 items, the subsidies and the tax credits, are only available for coverage that's purchased through the health exchange. So what is an exchange and what does it do? Well, you can think of an exchange, this is only a part of it, but the visible part to the public, you can think of it as an online marketplace for insurance, kind of like Travelocity or Expedia. You'll be able to put in certain basic information about yourself and then be able to determine what options for health coverage are available to you. You'll be able to compare plans, their benefits, their costs, your out-of-pocket expenses. All of that is supposed to be available through this online marketplace. But the exchange also has to do a number of other things. So the exchange, first of all, will determine which plans can be sold on the exchange. They'll make sure that those plans provide all of the essential health benefits that are required under the law to be provided. They'll provide a toll-free hotline, make an internet website available for enrollment. They will also establish an electronic calculator so that you can try and determine which plan is best for you in terms of your out-of-pocket expenses and the providers that you use. They will also importantly determine eligibility both for the subsidies of the exchange and for the public programs. Because if you think about it, there's sort of an arbitrary line. If you earn under 138% of the poverty level, you're eligible for a public program. For Medicaid, if you earn above that, you're eligible for a subsidy. And they want to have like a one-door policy so that anybody can go there and find out what, in fact, they are eligible for. They will also be establishing a navigator program, and that is a program for, gets to be fairly complicated, so in order to properly inform people about what their options are and help them choose the one that's best for them, there will be navigators to assist them in the process. And then lastly, not lastly, there's other things they do, but the key one here is that they will certify individuals as exempt from the mandate or subject to the mandate. So let's talk a little bit about what those mandates are. So beginning in 2014, as I mentioned, there are mandates on employers and mandates on individuals. For employers,